everyone. It is noon now, so I'll begin. So I'd like to welcome everyone and thank you for joining today's webinar. I'm Sage Reiner. Here at Interior Health, I work with the IH Research Department. Our involvement has been a great partnership with a great group, Climate Change Working Group. We've done a ton of our webinars with them. Today we are presenting wildfires in BC, health effects and systems implications, and perspective by Lavery and Sarah Henderson. Sorry if I'm pronouncing those wrong. In this webinar, John will provide an overview of 2017 and 18 wildfire in BC, discussing the implications of these climate-related severe events from emergency management perspectives, with focus on health, care system impacts, and lessons learned from the consecutive years of provincial state of emergencies. Using environmental health lens, Sarah will discuss the severe smoke pollution that affected the province for weeks, placing evidence from BC in global context and highlighting critical gaps that researchers are looking to fill. So before we started, there are housekeeping notes I want to mention. The web platform uses teleconference for audio. As you've seen, you were given dial-in details. So please, sir, you have your microphones muted unless you are speaking. If you have any questions during the presentation, please feel free to type them in the question box on the chat portion I mentioned. I will then note during the presentation, and we will have time for questions at the end. We will be recording the session and sharing with you afterwards. Nicole Spence will now provide us with a brief introduction to the series and presenters. Nicole is coordinator with Health Emergency Management and a member of the CCGHR Working Group on the health impacts of climate change. Nicole.
Thank you, Faye. For those of you not familiar with this DGHR Working Group on the health impacts of climate change, it was in early 2018 to address the challenges at the intersection of health and climate change. Our mandate is to identify knowledge gaps through individual and institutional members, to communicate the current state of knowledge and awareness of drivers for and changes in climate-related health. So one of our activities to help address the gap is the webinar series, for which today's session is possible through our regional partnership with Interior Health. So thank you, H. I'm personally really excited for this one, not only because we have two amazing presenters, but it merges several areas of interest for me: emergency management, in which I work, global health, and climate change. So without further ado, I will introduce our first presenter. Slide, please, Sage. Lavery is the Executive Director of Health Emergency Management BC, or HEMBC as we call it, one that provides emergency management leadership and support to the health system in BC. That includes all the health authorities and the Ministry of Health. HEMBC supports hospitals and a wide range of other healthcare facilities and programs to prepare, respond, and recover from emergency events, including public health emergencies, flooding, and wildfires. John has been emergency manager for over 2 decades and has worked in the health sector for 19 years. He's an active member of the World Health Organization's Emergency Operations Center Network and co-chairs multiple Canadian and international committees. So over to you.
Nicole, and hello, hi everybody. So I'll start off with, if we go to the next slide, telling you a bit of an overview of the health system in British Columbia, just how we're organized. So in British Columbia, we have a Ministry of Health that provides strategic direction and policy direction to health delivery in the province. It all of the monitoring related to health delivery and provides the budget to the health authorities, around $19 billion a year. We're bound into, we have 5 regional health authorities that cover a geographic area. As they range from quite large to our Northern Health Authority to with a quite spread and dispersed population, down to our health authorities like Fraser Health, which is relatively small compared with other health authorities, but has a large population of 1.8 million people. Regional health authorities provide services in that area, including acute care, so all of our hospitals, rental and long-term care, public health services. In addition, Provincial Health Services Authority that my station is a part of, as is Sarah Henderson, BC Centre for Disease Control, and they provide provincial health services like the ambulance service as well. Cancer care led out of the Provincial Services Authority. Our Children and Women's Hospital are managed by PHSA as well. We have the First Nations Health Authority that is responsible for providing health services to First Nations communities and populations. In addition, there are other health services, of course, that are provided through primary care physicians who are private but are still funded by the provincial government. Move on to the next slide. So Emergency Management BC, as I mentioned, we're a part of the Provincial Health Services Authority, and we support all the health authorities as well as the Ministry of Health in for emergencies. So that includes leading initiatives across all of our facilities and programs on the levels. We also organize and manage staff training and education, so we deliver training on a regular basis in our facilities. We also run emergency exercises. We support emergency response. And then after emergency has occurred, we support the process to gather lessons learned from those events. And we actually work to track those lessons or make sure that we are actually implementing the things that we've learned. Elder engagement as well is a very important part of our program. Next, please. This is an overview of the wildfires that we experienced over the last 2 years. In 2017, we had a very demanding spring flooding season that attacks across the province, and that started in early May. And then after that, we saw a really unusually early and active start to our wildfire season. As you know on that slide, we had over 1,300 wildfires, affecting over 1.2 million hectares. At the time, in 2017, that was a record in terms of hectares burned. Used fire suppression costs there as well, $556 million. So a lot was spent just on fire suppression. For 2017, there was a lot of people were evacuated. This is a record for British Columbia, with over 65,000 people evacuated. And these populations went north into Northern Health, they went south into other parts of Interior Health, and they also went into the Lower Mainland and spread out across the country. In fact, we lost a lot of structures that year, so there were quite a few homes and other buildings were lost. And I see that we were in a provincial state of emergency for 71 days. That's a really unheard of in the past. That was a very long time for us to be responding to events. So a very large number of people evacuated, so very significant impact. 2018 came along. We also started with a significant flood season. Parts of the northern interior, like the area around Grand Forks, were pretty significantly flooded and are feeling the impact from that now, or still. But we had over 2,000 fires burning in a larger area, so 1.3 million hectares. Farm costs were a little bit less. What was very different for 2018 was we had a smaller number of people actually evacuated at only 6,000 people. Fewer structures were lost. So we were under a state of emergency for a period of time, primarily because the areas where the fires were burning, first of all, they were quite spread out across the province as opposed to in 2017 when they were very focused in the Caribou area province. In 2018, a lot of the fires were in more remote areas where there were fewer people and fewer communities to be impacted. However, as you'll hear, there were pretty significant smoke impacts. Moving to the next slide. So specifically about the health system, this infographic was produced by Interior Health after their fires, and a couple of things draw your attention to. The blue, there were 880 patients or clients evacuated by Interior Health during the wildfires in 2017. That's a very large number of people that were moved. In addition, over 700 staff were displaced. So while evacuating communities and evacuating patients, all staff often have to be evacuated as well because they're living in those evacuated communities. And there's a whole range of challenges that come with that. You'll see that 19 Interior Health sites were closed as a result of the wildfires. One note here is we're talking about relocating patients often, and we're talking about closing facilities. things that we do in British Columbia, and Interior Health has been especially good at this, is when there is a community under threat and there's an evacuation alert issued, not an order, but an alert, is we assess the risk and we actually start to move our patients then. So actually we'll move our long-term care patients then, and we'll move patients out of hospital as well, so that we can actually move patients in a really safe way. And but by doing that, we're not scrambling when the community actually goes to an evacuation order. I think it also has been really good at being proactive in these sorts of things. So just some of the facts from 2017, you'll see it was a pretty significant impact on that health authority. So moving on to the next slide. The wildfires and the flooding have significant impacts on First Nations communities, often which are located in more rural areas. In 2017, we had 28 First Nations communities were either evacuated or on evacuation alert. In 2018, there were 31 First Nations were impacted. And in terms of flooding, approximately 23 First Nations were impacted by flooding in 2017 and 2018. And also a number of these communities had flooding, and then they were impacted by the wildfires. So again, there's a pretty significant impact on First Nations communities, and they are disproportionately impacted. Moved, and is really important to be proactive so that you can be moving patients safely. Again, patients that were receiving care in the community were evacuated. So when that community actually evacuates patients that are receiving home care or who are accessing services in the community like mental health services or dialysis, things that they are also impacted to be moved, and that's a big burden on the health authority as they need to try to ensure that wherever those patients go, they're getting care as well. I mentioned well, health staff are also evacuated. Have healthcare appointments, procedures booked. They have to be postponed or scheduled. And programs that are in those areas are suspended. So if there are, any health program, it might even be educational programs for new moms or new families. Those will have to be postponed as well. So which is very, very challenging. So public health issues, especially considering around the re-entry into a community that has been evacuated, might be related to water quality. If power's been out in homes, there will be food spoilage, and need to be assessing that as well, or looking at that as well. The mental impacts cannot be really need to be considered. And that basically everyone who's involved with that fire, with those fires and those evacuations can be impacted, whether it's patients that are moved, our staff that are moved, those that are responding, also those that have evacuated. The recovery aspects of these events have been significant, and a lot of attention and effort has gone into looking at recovery broadly across all of these possible impacts, but for our programs, especially looking at the mental health and wellness impacts, and support these communities through their mental health recovery. As well, for all of these events, we have to activate our emergency response structures. We have we have a response structure, and at every level in the health system there will be an activation. So our facility will be activated to support the movement patients. So they'll be activated to receiving patients as well. So if you're in a health authority that's receiving evacuees, you'll have to be considering that as well. Authority structures were activated, and our provincial structures were activated as well. So next slide. In an event, we always conduct after-action reviews, and these are conducted at multiple levels. So our facilities will conduct these after-action reviews, our health authorities, and then provincially as well. And these are looking at just trying to gather lessons learned, trying to learn what went well and that we can repeat in the future, where are some challenges that we need to address, and what we can do differently next time. And all these actions are put into the tracking systems that we ensure that that we're actually addressing these issues, and that we, as much as possible, we are ready for future events. So, again, we've got hundreds of recommendations from our last couple of years that we're addressing at various levels, but there's just a few that I wanted to highlight. In any emergency response, there are always issues that are addressed related to ensuring clarity of roles and responsibilities, and that our response structures and processes are working smoothly. In 2017, we definitely had a number of recommendations released. As a result, we developed an updated wildfire response plan, which really tried to clarify roles, responsibilities, and how we communicate and function during an event. In 2018, we activated that plan, and things did go more smoothly. But this is an area that, again, that's addressed following pretty much every event. We try to learn lessons about how it went and update our plans and processes accordingly. Evacuations, as I mentioned earlier, there were good decisions were made by Interior Health to move their patients and clients early. Those are tough decisions to sometimes, because you might evacuate a community and then there's no evacuation order issued, and so people start to question, well, was it worth all the effort and the expense and the disruption? I think it's always better to go with that no regrets approach and evacuate early and accept that there's some costs, and sometimes you may not get it right. As a result of these events, we have developed updated guidelines for our facilities and for our leadership to help them make decisions and to support their response. One of which we are still working on, however, is around our emergency social services programs and ensure that it's very clear how support for evacuees is provided. If people evacuate not as part of an actual evacuation order, but if they're evacuating because they're concerned about health in a very smoky situation. And so some of those pieces are still being worked out. Individual safety are very significant. I mentioned a large number of our First Nations communities were impacted, and they're evacuating. And I think across everything that we do in emergency management, we have to ensure that we're working very closely with First Nations communities, and that we're working in a way that is culturally safe, and that we recognize the complex nature of intergenerational trauma in these communities. It's really important, and we're doing a lot of work working directly with our First Nations Health Authority and communities in the area. Impacts as well. When it comes time to responding to an emergency, our staff do system, and they do what needs to be done to support patient care. That's really their priority. We have to make sure that we're doing as much as we can, however, to support them when they are also evacuating, and recognize that they're going through a large event. What we did develop in British Columbia is we now have a health workers registry, so that staff from all the health authorities can sign up for this registry, and if another health authority is looking for staff to help them with their response, they can actually go to the registry and basically do some recruiting at the time. So the North needs some additional nurses. They can look in the registry and they can make requests, particularly for mutual aid. So we have quite, I think, over almost 200 people are signed up in that registry right now. In terms of recovery, this is an area that we've always known is important, but I don't think we recognize how large it is, how significant it can be after a large event. Again, a lot of attention is going into this area. In fact, Emergency Management BC, our provincial agency responsible for emergency management, has created an assistant deputy minister position that has responsibility for recovery, and actually added a number of staff. Currently developing a recovery framework for the province, which will include a mental health and wellness recovery strategy, so that when events are occurring, we know how to actually activate a mental health recovery effectively. You'll be hearing more about this from Sarah, so I won't get into that. And we are really asking the question: is this the new normal? Is this the new normal for us with change impacts? Are we what we're doing every summer now going forward? Is smoke a new normal for us? A lot of questions about, and if that is the case, how does that affect our emergency management programs? And how do we do things differently? Do we have to be resourced differently to address these? I think one slide. That's an area. This photo is a good reminder that so these are all babies that were born to residents that were evacuated during 2017. So while they were evacuated, they had babies. A reminder that when emergencies are occurring, life is still continuing as well. People still have babies. People still have heart attacks. People still, the healthcare needs to continue. And so we need to really ensure that we are prepared to continue our services during evacuations as well. So that's for my part. I'll pass it back to you, Nicole.
I'm just going everyone to hold off on any questions until the end because we're experiencing some technical difficulties. Some people aren't able to hear. But if you do have any questions or comments for John's presentation, please put them in the chat box on the side, and we'll make sure we capture them and come back to them after Sarah's presentation. Before we jump into Sarah's, I think I'm going to try and troubleshoot this issue. I know you can't hear me, then you don't know to dial in, but we're trying to get a few people who have not been able to join the teleconference because apparently it is full. So just stand by for 1 minute. Okay, I think we are ready to go to the next presenter. If you mind. Thank you. Henderson is an associate professor at the University of BC and a senior scientist with environmental health services at the BC Centre for Disease Control. She started her career as an environmental engineer working on pollution abatement and control, and then switched her focus to environmental epidemiology when she first became interested in the public health consequences of engineering decisions. At the CDE, she leads a program of applied research and surveillance to support evidence-based policy for the province, where she spans a wide range of topics, including air pollution, extreme weather events, radon gas, food safety, water quality, and exposures. She's an international expert on the health effects of wildfire smoke and has been studying this topic in BC and in the world for more than 15 years. So, over to you.
Thank you. And I think you were going to hand me control so that my slides looked okay. Is that correct?
Yes, I believe Sage will pass the ball to you.
Ice ball. Still see anything.
I think Sage is.
Oh, there you go. I am now the presenter. That's okay.
There's something happening in the back here.
Is he seeing my slides?
You need to hit the share screen button.
Now the presenter. I not see it showing me with the. I have.
Can you hear?
There we go.
Okay.
Got it.
Sounds good.
I'm there. I'm slow, but there. Can you now see my screen?
We can, definitely.
Great. Okay, sorry about that little glitch, folks. I hope everybody's got their sound back. Thanks for the nice introduction. Also, I am primarily a senior environmental health scientist at the BC Centre for Disease Control. I've been studying wildfire smoke in BC for a very long time, and I have to say that I learn more and more every year. So I just want to share with you some of what we know about the health effects of wildfire smoke in general, and then specifically what we know from the BC context. The picture you're seeing here comes from one of my colleagues in Northern Health. This is in Prince George, and I love it because it's a juxtaposition of something that should be really fun for kids compared with something that's not really fun, which is extreme wildfire smoke and pollution. And I think this is what we've seen in many communities across BC for the past couple of years, but I do want to remind folks that wildfire smoke is not a new issue in the province. It's become more widespread in recent years, but seasonally we've had wildfire smoke, especially in some of the interior communities, year after year for many years now. First, talk about what is wildfire smoke and the trends that we've observed over the past decade or so, the health effects we've observed in that same time period, and I want to put that in context of what's known from the global literature, I will say that BC is the leaders in this area, so we've sort of always been at the forefront of generating evidence that gets used worldwide. And the really big evidence gaps are, from my perspective, at this time and given the events of the past few years. Wildfire smoke, oh, somebody's got to mute. Wildfire smoke is an extremely complex form of air pollution. There's this temptation to think that smoke is natural because it comes from wood that's burning and therefore it's not dangerous to humans, and that is incorrect. Wildfire smoke is a form of air pollution and it carries the same human health risks that other forms of air pollution, such as automobile exhaust or industrial emissions, carry. There may be some slight differences, but wildfire smoke is not good for your health. When you consider this mixture, there's a whole bunch of gases and there's fine particulate matter. You could grab a sample of wildfire smoke and then 10 minutes grab another sample. You would find the composition of those two samples to be quite different because it changes so quickly. From a human health perspective, the thing that we focus on is fine particulate matter, or particles that are less than 2.5 microns in diameter. And in reality, wildfire smoke is generally less than 1 micron in diameter. The smaller the particles, the deeper they can penetrate into your lung, and the more disruptive they can be to human health. So first of all, they be these surface reactions to wildfire smoke. People's eyes sting, their throat gets sore, people get nose, that's what I'm trying to say. There's nasal irritation, and that's just from contact with wildfire smoke, which can be very irritating, especially when there's a lot of volatile organic matter in it. But then once it gets into the lungs, what the body does is treat it like an invader, basically, as if it were a virus or a bacterium, and there's an immunological response that gets mounted against the smoke. And because the smoke can't be killed like a virus or a bacterium could be, the immunological response is sustained. And this puts people into a state of inflammation and oxidative stress, which does not only affect the lungs, it affects the body and every organ system in the body. So it's easy to understand how wildfire smoke might have respiratory effects, but it actually has whole body effects. The important variables to consider when thinking about the smoke mixture are what's burning, if forest, what type of forest, if it's forest and smoke, if there's a lot of anthropogenically created materials in there. The moisture content, which dictates how hot the fire can burn, because the smoke from very hot flaming fires is different from the smoke from smoldering fires. The meteorological conditions, how hot it is, how damp it is, how windy it is, and how far the smoke has traveled from the fire. The smoke ages as it travels, so very fresh smoke is quite different from aged smoke hundreds of kilometers from a fire. This is a slide just showing us what the fine particles look like. So PM 2.5 are these pink balls. That's how they compare to the size of a human hair. But I guarantee you that smoke is not pretty pink balls floating around in the atmosphere. It is tiny, little, ugly clumps of sooty particles. So it doesn't really look anything like this. One of the things the BC CDC is currently working on is trying to create a similar image to this specifically for wildfire smoke to give people a better idea of what this stuff is. When talking about the health effects of pollution from fine particulate matter, we have to consider the time scale that we're talking about. So that people who live in more polluted cities day in and day out, year in and year out, have lower life expectancy, higher incidence of chronic diseases because of that exposure to air pollution. And when we consider the total burden of illness caused by air pollution, we actually attribute about 80% of that total burden to what you're exposed to day in and day out, year in and year out. And then about 20% is attributable to day-by-day fluctuations. So this is the PM 2.5 24-hour averages for Kamloops during the summer of 2017. You can clearly see the wildfire smoke impact in the summer here. And what I want to point out to you is that wildfire smoke doubled annual average of PM 2.5 in Kamloops for 2017. So, fluctuations that happen during the wildfire season were large enough and sustained enough to really change people's exposure in that entire year. And that's one of the things that's concerning about this new sort of fire and smoke regime that we're seeing. Just over this already, I just want to paint it out a slightly different way. I always say I started working at the BCCDC in 2010, and we've had a number of severe wildfire seasons since I started working there. Previously, I would have called those seasons shown in gray as typical wildfire seasons, whereas those shown in orange or red would be more severe wildfire seasons based on the history since the early 60s. We have seen is 2010, 1958 aside, 2010 was a record-breaking wildfire season, and then 2014 was another record-breaking wildfire season. And then you can see how different 2017 and 2018 were in terms of area burned, and those differences play out in the smoke impacts as well. So what we're looking at here now is the population-weighted average of daily PM 2.5 exposures for all of British Columbia. So on average, what the average British Columbian, and there's 4.8 million of us, was exposed to on these days. So this is 2017. You can see it's relatively low. 2007. This is 2008. And here we see the worst kind of one-day exposure on record. It's about 20 micrograms per meter cubed. That's still lower than the provincial PM 2.5 objective, which is 25 micrograms per meter cubed. We move into 2009. We see something similar. Then move into 2010, and we're up to 40 micrograms per meter cubed. 2011 was one of the mildest wildfire seasons we've had on record in the past decade. 2012, another mild season. 2013, 2014, no big. Then 20. The smoke from Pemberton area into the lower mainland and the southern Vancouver Island. We go up to 6 micrograms per meter cubed. 2016, mild again. 2017, we get up to 8 micrograms per meter cubed. And just look at how sustained these high exposures are. And then 2018, we set a record at 100 micrograms per meter cubed. So on this day in 2018, every person in the province, on average, was exposed to that much smoke. So hopefully this paints a picture of how these air quality impacts of this changing fire regime are playing out. Now I want to talk about what we know about the health effects of these exposures in BC. And this is a little bit difficult for people who aren't used to looking at information like this. So first, let me explain to you what's happening here. On the left-hand side, we have something that's called a risk ratio. And if we look at this first dot here, we can see the dot sitting at 1.06. That means there's a 6% increase in this outcome. So if you see 1.08, that dot here, that means it's an 8% increase. And we have these lines around the dot, those are the confidence intervals. If those confidence intervals are over the dashed line at the bottom here, we call that a statistically significant result, meaning that we feel confident the true value of the increase is somewhere within those lines. Increases are expressed for a 10 microgram per meter cubed increase in PM 2.5 on days. So we're only looking at days that we knew to be smoke impacted. 10 micrograms per meter cubed is not a very big increase when we consider that this is 100 micrograms per meter cubed, and we can often see in BC communities impacts up to 300 micrograms per meter cubed on the smokiest days, if not higher. So we're expressing this for 10 micrograms per meter cubed. The ones in blue are related to medication dispensations. So we see for each 10 microgram per meter cubed change on a smoky day, a 6% increase in Ventolin dispensations, or the blue puffers that with asthma or chronic obstructive pulmonary disease might use to help exacerbations of their condition. On the cardiovascular side, we see about a 3% increase in nitroglycerin dispensations. That's what people might use to control unstable angina. So we have evidence that people are going to the pharmacies and filling these prescriptions on smoke days. The red dots are related to physician visits. So these are outpatient visits, people going to walk-in clinics or their family physicians for complaints of respiratory illnesses, asthma specifically. We can see that's a bigger increase. COPD is a somewhat lower increase, but it's still there. Ear infections, these are primarily in children. I'm sure those of you who have kids will have experienced an ear infection. We know that there's an increase in these infections when air pollution is increased. And the same for lower respiratory infections. On the cardiovascular side, we see a very small increase, 1%, for people going for cardiovascular reasons. And then in black, I want to point out that these are unpublished data, but I'm presenting them because I think interesting to know. We've just submitted this study. We have all respiratory deaths, specifically to COPD. Those are about the same, although the COPD estimate is not statistically significant. And on the cardiovascular side, we have all cardiovascular deaths around 3%, and then specifically stroke deaths up to 8%. So there's not a lot of deaths across BC on a given day. There's about 140 across the whole province, but we do see these slight increases for deaths of a certain type. So that might amount to 1 or 2 or 3 extra deaths in a day during these very smoky periods. It's a bit easier to measure things like the number of extra puffers that have been dispensed or the number of extra physician visits. And when we combine the data for both 2017 and 2018, we estimate there was about 43,000 extra Ventolin dispensations during the most impacted 8-week period between July and September, and about 10,000 extra visits for asthma-related complaints. So when thinking about the burden to the healthcare system, that's in ways a bigger concern than the small increase in mortality. So of course, both are concerning. Now, to put this in the context of the global literature, it is consistent with what's being found in other places, especially California, which is quite comparable with the BC context, and in Australia. So what we see in BC is similar to what's being observed around the world. There's more evidence coming out about specific cardiovascular events. There was a while where the literature wasn't picking up those effects very well, And that's really because the effect on the cardiovascular is respiratory, and wildfire smoke events didn't last for as long and didn't affect such large populations. So that makes it statistically challenging to find what you're looking for. And that we are getting these bigger events and these larger populations affected, unfortunately, it's improving our ability to detect these things with epidemiological tools. So we can now say with some certainty that there will be more heart attacks, more unstable angina, more heart failure, and more stroke during wildfire smoke events. Likewise, we're learning more about what the effects on pregnant women are. There does seem to be an association with preterm birth, and maybe quite a strong one. And then a lesser but still significant association with the birth rate of babies who were born in utero being smaller than babies who were not exposed. We're also seeing that these events have effects on people's diabetes. It interacts with their insulin management, so they are a population of concern. We heard anecdotally, and I know some people are starting to study this now, that anybody who's in a state of cognitive decline seems to have more cognitive difficulty when it's smoky outside. That makes sense on a biological basis, but we need to generate the evidence for that. And an area that really isn't well understood yet is the mental health impacts of these smoke exposures, especially when they persist for weeks and in some cases months, like we've seen parts of British Columbia for the past couple of years. I just want to talk quickly about what information we still need. More on the toxicology of smoke is necessary. There's some coming out now that different types of fuels have quite different impacts in terms of their toxicology. Pine smoke seems to be somewhere in the middle of the toxic range, and that's the predominant kind of smoke we will have in BC, so more is needed there. We also know that peat smoke is at the higher end of the toxic range, and we certainly do have peat fires in the province sometimes. We need to know more about babies who are in utero and born into smoke. There is the potential that these smoke exposures have lifelong impacts for those populations, and that's a really important outcome to consider. If you were born low birth weight because of the smoke, early because of the smoke, and that affects your health through the rest of your life, we really need to target pregnant women and people caring for infants in terms of making sure they minimize their smoke exposures. Again, more on mental health impacts and health impacts in highly vulnerable populations. Certainly the Indigenous populations in BC come to mind. And there's this huge question of the chronic health impacts. We really don't know if a population that's exposed to smoke year after year is going to have higher risks of reduced life expectancy or chronic disease than populations that are not so exposed, and we need to start building that evidence. On the right-hand side, I just want to point out this was a study done in infant rhesus monkeys, but it's useful to keep in mind these were monkeys born in California at a research facility. They were born in very smoky conditions, and then they followed these infant monkeys through the first 3 years of life. And they found that the lung volume of those exposed monkeys was significantly lower than the lung volume of non-exposed monkeys. So again, this indicates that there might be lifelong impacts for early life exposures. What about smoke? There's good evidence around using portable air cleaners indoors, especially in homes to help shelter in place. This is from my Prabjeet Barnes. On the left-hand side of this plot, we have indoor and outdoor concentrations in gray and black, respectively, and the filter is not turned on. you can see the indoor inundation of outdoor smoke quite clearly in the indoor signal. And there's the black line down the middle. The filter goes on, and outdoor smoke remains quite high, but the indoor stays quite low. So these aren't our perfect technology, but in general, most studies show that they provide about a 60% reduction in indoor smoke, and that's useful. More and more about masks. The advice to date has been that a well-fitted 95 respirator can offer protection. It's difficult to get a good fit. All of that standard messaging. There's actually increasing evidence that a non-well-fitted respirator can also offer some protection, and other types of masks that don't have an N95 certification can offer some protection. So there's growing information here, and the need to synthesize and review and refine the messaging around masks. The BCDC is right now wrapping up an evidence review on all of the new information regarding masks, and we'll be out with our proposed new messaging over the next few months. So that's an area that's changing a little bit based on new evidence. Finally, preparation for wildfire smoke is key. My line for the past couple of is we just have to go into every wildfire season expecting it might be the worst we've ever seen. We can hope for that, but we just have to be prepared for the worst. So I'm really happy to see lots of people talking about wildfire smoke right now. It's been in the news. There's been a couple of big articles on it. This is really the time of year where we want to start priming the population for the potential of a smoky summer. I would love to see an annual smoke readiness in BC or across the country. Clean Air Day is in June, and that's going to be a little bit too late. I think we need to do a better job of providing one-stop online information or through some sort of smartphone application where people can get everything they need to know in one place. Currently, the information is very disparately distributed, and we're working to try to centralize it somewhere. What you see on the left here is one of 13 fact sheets that the BCCDC is producing. This should be available on our website now. It isn't quite yet because I have no control over that, but in the coming days, the 3 fact sheets will be available on the BCCDC website. They cover how to prepare for the wildfire smoke season, the general health effects of wildfire smoke, and then portable air cleaners, what they can do, and how to consider purchasing one for your needs. So hopefully that's an overview, and I didn't take up too much time. Thank you.
Thank you, Sarah. That was great. So now we can open up the WebEx to questions and discussion. So just a reminder, you can type your questions into the question box. You just have to click the chat button at the top right and make sure that you're sending to everyone or to myself so I can see them. Or you can just unmute your phone and we'll be able to hear your audio.
Can you hear me, Nicole?
Yes,
so I'm just curious about BC's international or BCCDC as just talked about BC's approach and interventions. I want to know what their national engagement has been, whether they can get by themselves or they've engaged other nations, being it Australia or the US, or I just want to understand the knowledge sharing activities when it comes to these issues.
So if I understand the question is, what national agencies have we engaged in with this work?
Right. Mm-hmm.
Okay. Sarah, did you want to add anything to that?
So we don't engage with all international agencies. We do, BC has a specific kind of context, and we like to engage with others who are working in the same sort of context. So primarily it's been with the U.S. and Australia, where their situations are as similar as possible, and less so in Europe, which also experiences extreme wildfire episodes, but it's somewhat different. So we worked quite closely with the US EPA on lots of these issues, and specifically with collaborators in California, and quite closely with mostly the state of New South Wales, Victoria, and Tasmania in Australia.
Thank you.
Do you want to add anything to that?
No, sorry, no, Nicole.
Okay.
Well, I was wondering, maybe I could just say that in emergency management, we do work with colleagues across also in the Pacific Northwest. Also, we do engage with groups like the World Health Organization's EOC network. So we do connect in with other organizations around the world to really to make sure that what we're doing is based on the best practices and current and lessons learned research.
Does anyone else have a question?
All right, thanks very much. Mm-hmm. Yeah, thanks a lot.
I've received a message here. Sarah, this might be for you. How do you see the learnings from what you've here, like with the diabetes management and the high-risk groups with pregnant women? How do you see that translating to a global context?
The same has been observed for diabetes in Australia, again. So we know that that's similar. Some evidence on pregnant does come from a more global context. So there was extreme wildfire smoke haze in Asia in 1997 1998, caused by the strong El Nino that year. And previous to the past few summers in BC, we haven't considered that to be evidence that was directly relevant, because the episode lasted for a couple of months and the exposures were very high. But when you look back at 2018 and 2018 for BC, it's actually very similar to that episode, and they found that their birth cohort was about 1% smaller following those exposures than would have been expected. So not even birth comes, there's just a smaller number of births, probably due to spontaneous abortions. So I think what is relevant to other countries and what other countries are finding is relevant to us.
Mm-hmm. Yeah, I certainly see the relationship, because as we're seeing an increase in the duration and the severity of the wildfires and the smoke across Canada, it's also a global trend, and how we prepare our healthcare system and adapt to the new norm will have impacts globally. And like you said, learn from others, and others can learn from us, certainly with the populations that are disproportionately affected, including the remote and Indigenous communities. So identifying those unique circumstances that certain groups face can help us identify the vulnerabilities, but as well as their resilience.
Take a moment to say, we're working on getting a study funded around birth outcomes and early life outcomes in BC, but we've given pregnant women and infants, the sort of the typical lip service to date in terms of messaging. I really think we need to pull these from available evidence. We need to pull those populations to the forefront. That's why I love John's picture so much with all those babies. That's fantastic.
Mm-hmm.
Hello.
Great. Hello.
Yeah, hello, thank you. This is Bala speaking from Thompson Rivers University. Thanks to John and Sarah. This is really, really useful. I have a question here for Sarah, kind of an observation. You mentioned there's a lot of impact that we see on smoke and the birth and the mental and cognitive abilities. I wonder, any studies you are planning to look at the exposure by the indigenous children who are supposed to be 10 times or maybe more exposed to smoke because they live in those areas compared to the children in Kamloops. So I'm planning to do any studies between the school-going children and into these things.
If we had all of the money in the world to do all of the research in the world that we wanted to, I would be. We're actually having difficulty getting this first study on pregnant women and infants funded. So down the line, I hope so, but it's not something we have explicit plans for at this time.
When you're saying that we don't have any information about indigenous children and their exposure to smoke.
Saying that we do not have any specific information about indigenous children and their exposure to smoke, we actually have less information than we would for other children because there's very limited air quality monitoring in many indigenous communities. So we only sort of know from hearsay what those exposures might actually be.
So that takes the question to John. John, you mentioned there were 65,000 evacuations in 2017 and only 6,000 in 2018. I was wondering, is it something related to the smoke and smoke exposure, or what is it? Could you say something about that? How can we reduce from 60,000 to 6,000?
Sure. In 2017, the wildfires directly threatened a number of fairly large communities. So communities had to evacuate completely to get out of the way of the actual flames of the fire. In British Columbia, we don't do any formal evacuations because of smoke. There are populations that do move on their own as a result of the smoke and to try to get into areas of cleaner air. So in 2018, we did have had a large number of fires and more area burned, but just fewer communities were directly threatened.
So you're saying that we don't have data again, people who move basically evacuate voluntarily because of smoke. If we include those numbers, then it will be definitely, it crosses, 100,000.
It's to say, so people that evacuate, I'd have to check exactly what those numbers are based on. If they're based on just the size of the actual communities, or if those are based on the numbers of people that actually go to to register as being evacuated. Because when you do evacuate, you are eligible for some support. I expect those numbers are based on the number of people who actually registered as evacuees, and often the people who evacuate for smoke are registering as well as evacuees. So I could check into that further, though. It is a good question.
Thank you.
One of the things about smoke you see over the past 2 years is that where to evacuate to, we've had days where the entire province, with the glaring exception of Haida, have been covered in smoke. So it's not, like you can easily say, well, if I move from this part of the province to that part of the province, I won't be exposed because the whole province has been exposed.
Yeah. Because I come from Nepal, and I worked in 2015 Nepal earthquakes. People are displaced, and there are different types of displacement I have seen. People are displaced for a long time, a long distance. People displaced for a short time and short distance. People moved, for a long time, but a short distance. So I'm actually looking at the similar patterns in wildfires in Canada. I'm very new to British Columbia. I'm a new recruitment in Thompson Rivers University. I'm basically what I can see the similarities between types of displacement, whether it is earthquakes or wildfires. So likely there are very similar familiar displacement patterns I'm beginning to see. So I'm basically interested in whether there's any work being done, and that displacement pattern also will have an impact on interior health and the services the interior health is providing, I guess. So is there any work done on displacement pattern, why people move? Evacuation is something that involuntary displacement, I would call it, because you've been issued an order, right? So is there any work carried out I should know? John, could you say something?
Yeah, I'm not aware of any work on that topic specifically, so I'd be it's something I'd have to check in with our management British Columbia to see if they have any research on it. I'm not aware of any though.
Okay, thank you. I have a few research ideas here to
Hello, everyone.
to start doing research in TIU. Thank you. It's very useful.
Hello, everyone. It is 1 o'clock now. I don't want to take more people's time. I know time is precious right now. So I'd just like to thank all the presenters today, and Nicole and John. This is a wonderful presentation. We hope, we can further continue this conversation at another time. But how heard everything, Nicole?
Yeah, we share contact details and information about the working group if people want to carry on this discussion, because there were some really great questions that were raised. And I know, unfortunately, some people were not able to join the audio. So we'll follow up with everyone, all the registrants, with the recording, as well as further information to keep these conversations going. And thank you, Sage, so much for hosting.
Thank you, everyone.
Thank you.
Thank you.
Thank you.